Prof. Wan Zamania. Okay, let's go to the first case. Just a reminder, there might be some provocative questions just to initiate some discussion so that a lot of people can benefit from the session. Okay. First case is a 60-year-old lady with increasing neck swelling for the past 1 year. Together with this, she has worsening hoarseness and noisy breathing and dysphagia for 2 weeks duration. These are all associated with reduced effort tolerance. So let's just go back to history. This patient is a known case of papillary thyroid cancer, diagnosed about 6 years ago, had a total thyroidectomy and was told by the children that she had a tracheostomy inserted, was there for only 2 months before it got decannulated. They were not sure whether there was any nerve injury or not. It was not told to them, but what they say is that there was hoarseness of voice following surgery. She received radioactive iodine ablation at 150 millicurie during the same year, and she was went for follow-up only until like 4 years later developed another neck swelling with a raised TG. At this point, she was still followed up outside, not in our hospital, and the children claimed that she received another RAI during the same year at 2019. Following that, for the next 2 years, the neck swelling had increases in size, and again, the last visit to the hospital or clinic, she was scheduled for whole body scan that was done in April last year, before she came to us about a month later with current presentation. Her TG at that time was 551. Maybe if we go back to this history so that we can have some idea of what's going on with this current problem. I know that the patient is having difficulty in breathing, noisy breathing at the moment, but we can forget about that for a moment and go back to here. Maybe I can get Dato' Imi to tell us how frequent do you actually see a well-differentiated thyroid cancer that do not really respond to radioactive iodine?
Oh, okay. For a DTC, differentiated thyroid carcinoma, that respond to RAI usually is about 20 to 30% of the cases.
Oh, that's quite high, 20 to 30%. What would be the factors that you have noticed that actually put these patients at high risk of having recurrence?
I'm not too sure exactly why actually, but because most of my cases that after we operated, such as total thyroidectomy with neck dissection, so means that we refer straight away to the radionuclear medicine for RAI, and then after subsequent follow up with them, and we noticed that the tumor remnant become increasing despite they have been giving RAI quite a high dose. Maybe Dr. Zamania can
maybe Prof. Wan can elaborate on that. Do you have any kind of risk stratification that you use to manage this patient along the way with response to treatment and everything?
The usual type of patient that will not respond very well to radioiodine, from my own experience, is the one yang has high risk variant like tall cell, like Hertel.
For example, this is a pure papillary, not
that many
stick type.
No, I don't see that many, but eventually after some years, they may develop radioiodine non-avid. I suppose the thing that we haven't done in Malaysia is the molecular profiling, which could contribute to the tumor being radioiodine resistant.
Yeah, so that is probably one of the reasons why, but we don't actually really do it here. Yeah.
Correct.
I agree with Prof. Zamania because we are lacking of profiling in terms of genetic genes of the tumor.
Yeah.
For Prof. Wan Zamania, do you normally increase the dose of radioiodine ablation along the way if you see that the patients did not respond from the previous treatment? And if yes, what's your cutoff value of stopping treatment in this patient?
In metastatic disease or local recurrence?
Local recurrence that's still taking up iodine.
Do they surgical candidate?
We will go to that surgical candidate. What's your cutoff value or point for surgical or size? I might say to be surgically resectable. Yeah.
Normally, I will refer them to my MDT team meeting and then asking our surgeons if they any contract indication for surgery. And if there's none, normally I don't really have certain cut off point of where I would say that this patient is not surgically amendable. Usually, I will refer to my surgeon if they think that they can do the surgery. I will ask them to do, and then I will ablate the patient after that, or offer them radiotherapy.
Okay. Any maximum dose of radioactive iodine ablation for patient? No, yeah?
No.
All right. Okay, so let's just go back to the current problem. Oh, before that, maybe I can ask Prof. Marina. She had nerve injury sometime during this presentation in 2015 and had tracheostomy only for about 2 months duration. What could have happened during this time? That might.
Thank you for the question. It is a bit strange though. 2 months after surgery, tracheostomy tube was decannulated. There is one possibility when the tracheostomy tube, or maybe two possibilities, tracheostomy tube managed to be decannulated. Number one is after surgery, probably patient had bilateral recurrent laryngeal nerve injury. So the patient had bilateral abductor palsy, restricting the glottic area. Therefore, the patient need tracheostomy. However, in some proportion of patients, the bilateral changed to unilateral. One vocal cord become mobile. Now, instead of bilateral vocal cord paralysis with airway problem, the patient turned into unilateral, only have voice issue but do not have airway issues anymore. So that's one reason probably why the tracheostomy tube was decannulated or removed 2 months later. Or probably the other reason is, I'm not our practice here, if I do if the tumor has invaded the trachea in the lumen, I would remove the tumor and then put tracheostomy. Then after the patient received 1 dose of RAI, if there is no tumor in the lumen, I would decannulate the tracheostomy tube. So those are the two possibilities.
All right. Okay.
Yeah.
All right, let's just move on to what we have next. This is the example of the radioactive iodine map that the patient had. The one in January 2019, and then this is post ablation scan. The next one on the 30th January, a very good uptake in the neck and persistent uptake even in April 1st, 2020. Again, similar findings on spexity. Okay. Okay, so this is the patient. You can hear the 5A6 stridor. And we proceeded with ultrasound of the lesion. which showed about 3 centimeters lesion here, very vascular at the anterior part of the trachea. Vessels are okay. And the CT scan of the patient. The CT, I cannot get my cursor in. The CT showed the presence of tumor starting from the level of C3, up to T2 level, and destruction of the hyoid bone, thyroid, cricoid, erythenoid cartilages over the left side. So it's pushing all the tracheal structure to the right. Further down, there is no retrosternal extension of this tumor. Another view of the tumor, very extensive at the upper part of the neck, at the region of the thyroid erythenoid cartilages. And our ENT colleague had scoped this patient. She had a slit-like airway with mass effect from the left side. Sorry that I don't have picture for this one or video for this one. The right true cord was visualized but with restricted mobility, and the left false cord was seen but immobile. So the impression at that time was impending airway obstruction secondary to recurrent papillary thyroid cancer. If I can get Dr. Imi to let us know, based on the CT scan and all that we have now, is this patient surgical candidate? She has got diabetes, hypertension, but all well controlled.
Before that, can I ask one question?
Yes.
Did you biopsy the patient again?
Not yet. That
was
is
about to
for
ask the same question.
Dr. Imi to answer. Do you want a biopsy, Dr. Imi?
Yes, I would like to do a biopsy first.
How would that change your management?
No, but in terms of prognostication, you know, because the
Mhm.
last time surgery done was in 2015. Papillary CTA, right?
Yes.
And then it's recurrent. So it means after almost 7 years,
Mhm.
it's the recurrence. And then you have the recurrence with stridor. The presentation is a bit awkward, you know, because it came with stridor, and then there's a huge hardness.
So what? Yeah.
It might be the transformation from PTC, papillary thyroid carcinoma, into follicular or polydifferentiated thyroid carcinoma.
How would that change your management?
In terms of management, it won't change much because she's still young, and of course, by hook or by crook, she needs to do at least debulking surgery and put another tracheostomy to help out her airway.
Can we send that intraoperatively? Just a question.
Sorry, again?
Can we send the specimen intraoperatively?
It might not help so much because usually the pathologists, they don't.
No, I mean after surgery. That means debulk as much as you can at the first instance, and then wait for the results later on.
Yes, you should do a debulking surgery first. You remove as much as possible. And wait for the bar. And let's say if there is any remnant, you might give Prof. to give whether differentiated or polydifferentiated carcinoma, whether they can take iodine or not.
If you want to proceed for biopsy, what would it be in this patient?
And it might be because if let's say fine needle aspiration should be enough, but if let's say your radiologist is brave enough to do a true cut biopsy under guidance, it will be excellent.
Okay. All right. We didn't actually do a biopsy in this patient, but we had planned for the debulking surgery. Together, we actually had planned for debulking surgery. Maybe I can ask Prof. Marina on the ENT side? What would be the plan like with the extensive destruction of the upper part of the airway?
First of all, I would like to know the slit airway. Is it just at the glottic level, or is there any tumor below the glottis? I think looking at the CT scan, there is no tumor beyond the glottis inferiorly in the subglottic and trachea. So in this case, the patient wouldn't need tracheostomy under local. I think it's difficult though nak buat because there's mass anteriorly. So anesthetist would be able to intubate the patient either via video laryngoscope assisted or via fiber optic intubation. And then after that, after the endocrine surgeon had debulked the tumor, we put a tracheostomy tube in. However, if you think that this is not anaplastic transformation from papillary to anaplastic, and you think that you can the tumor is operable. Yeah, for example, it has not involved the prevertebral fascia, and then the patient willing for major surgery, then the ENT would do more than tracheostomy. We would do total laryngectomy, total pharyngectomy, and there would be some reconstruction need to be done.
Okay, may I get Prof? May I get Dr. Liu to lay down the plan for airway management, the strategy that you might have, and also your backup plan, if you have.
Looking at the symptoms that the patient had, of course, you always have to assess the patient and how impending is the impending airway obstruction. I think when I glanced through the CT scan just now, it looks intubatable. The slit-like airway, looks like it's still bypassable with the ETT. Now comes to whether the patient can, how is the neck mobility and whether your laryngoscope will be a problem. Depending on if the neck is mobile, and with this CT scan, and of course when the patient is having some tachypneic, it's not easy to do a awake fiber optic intubation. Sometimes you would probably just get enough of your gadgets, pre-oxygenate the patient maximally, and you go for one single attempt of intubation to try to get a tube in. And of course, when you were to attempt this, you always have to have your ENT colleague to stand by for your rigid bronch and also your jet ventilation to be ready. But from current case now, it looks like I would still go for this direct laryngoscope or video laryngoscope.
Okay, all right. Looking at the findings that we have now in the CT scan, how do you estimate the size of the tube that you're going to use? Roughly? Is there any...
Roughly, I would usually... you need a armored flexometallic tube, and you would go for slightly, probably one size smaller. If this is, I think, a female 60 plus, probably a size 6.5. The thing is, you cannot go too small because sometimes the too small tube, your length left outside is not enough. That's one. And then it's the smaller the tube, the more flimsy the flexometallic tubes are.
Okay. All
so
right.
Probably this would be something like a size 6, 6.5.
Okay. Actually, you did this case, Dr. Liu. So you managed to
I remember we had we had an MDT and was decided for a away fiber optic,
Yeah.
pre-MCO, and then we did this in April, post-MCO that, or during MCO that we were very wary of aerolization and we incubated with a video laryngoscope.
Yeah. So intraoperatively, the tumor was anterior and lateral to the trachea, on the thyroid cartilage, cricoid, and the first ring. We didn't disturb that. We were able to dissect the tumor from the lateral vessels, carotid and IJV. However, the tumor was not completely removed. Probably just 80% of the tumor was removed, and tracheostomy was put at the second and third ring. So HPE came back as pure papillary thyroid cancer, margins involved, and one of the nodes removed. I think the central nodes came back as metastatic PTC. So she was then referred for another repeat RAI in June. Yeah. The nerve, we didn't actually really look for the nerve because we didn't manage to get the tumor totally out, especially on the part where the nerve is, on the lateral part where the nerve entry is. We didn't actually disturb the tumor that region. So we didn't see the tumor at all, didn't see the nerve at all. Okay, so the patient was referred for RAI in June 2020, but she didn't go. The TSH at that time when she came to clinic was 57. So again in September 2020, she came back with another neck mass, quite huge, about 5 centimeters. And scoped by ENT team now saw kind of like a mass like structure at the left hypopharynx, which is slightly worse than before. So now whether I would like to ask of Marina whether is there anything that we can offer now with regards to these findings from the scope.
I think I could remember the scope findings. There is mass, but the mass is not fungating. It is kind of bulging in the hypopharynx region, if I'm not mistaken. It's not fungating mass into the larynx. It's like external compression tumor. So endolaryngally, I think that is we can't offer anything. We can debulk tumor that has fungate into the lumen. But if tumor still have a mucosa overlying it, then we wouldn't debulk that tumor, because if you open up that bit, that would you kind of opening the pharynx. You've opened the upper digestive tract.
Okay.
Because the mass and the hypopharynx is still covered by mucosa. It's not like fungating mass.
Now that the patient has got another new neck mass within a few months duration, so we actually did a CT for that, which showed current tumor at the left thyroid bed region with more or less similar features, destructive features on the thyroid cartilage, arytenoid, and cricoid. This is the tumor on the left side. The carotid and IJV. Alright, if I can get Dato' Imi's opinion on this, operable, not operable, go back in again. Hold on, yeah. No, actually. So it's going down. So this is the carotid and the IJV.
It looks like the IJV and carotid is fine.
Yeah.
symptom-wise, what does she have?
Just the swelling. Just the swelling. No more stridor.
I will just discuss with the ENT or ORL colleagues that would have activity, discuss with the patient as well as family members. What's our the direction of the management of this patient. If she's agreed for another surgery, I would like to have another debulking surgery for her. But provided there is not much harmful rather than harmful to the patient, right? That's why the need for NDP is really imperative here.
Prof. Marina, you wanna go in for your part, your surgery together with, because on the surgical part, the big vessels are spared. So can I say it's operable on our part, for Dato' Imi?
Because there is no clear plane of demarcation between the tumor as well as the thyroid. To the trachea.
Okay.
Even though the vessels are a bit away from the tumor.
Okay. So you think it's not really wise to go back in again?
I think it can be done.
Okay.
For debulking.
Okay. All right. So it's amenable for surgery. What would be the ENT side punya input, whether go in together, extensive surgery, or what would be the risk for the patient when it comes to extensive resection on the ENT part?
Okay. So the principle of doing major surgery of airway is whether or not the primary tumor, the thyroid tumor, you can remove totally. If you would just debulk, ENT also will do palliation, because you cannot like do massive airway reconstruction, but the fact that they still leave tumor behind. But if you think that the total thyroidectomy is possible, you can clear the tumor, probably just a small portion of it, and you want to leave it to RAI. Then looking at the extension of the tumor, the patient would need total laryngectomy. Total laryngectomy, the hypopharynx is involved as well, total pharyngectomy, maybe upper esophagectomy, and the patient would need reconstruction to cover the gap between the base of tongue and the upper esophagus. By using probably, we need to get involved for the reconstructive surgeon, getting like jejunal flap or stomach pull up or ALT free flap, anterolateral thigh, free, tubular flap.
Okay.
Yeah, so that lie on whether the thyroid carcinoma, the primary tumor can be removed totally or not.
On our part, I don't think I'm not sure. Dato' Imi, do you think we can on our part we can
I don't think
remove?
Yes.
Okay. All right. So plus the patient did not want to take all the risk of having extensive surgery, as mentioned before. So we went back in again. Just mainly on our part, the surgical part, we did tumor debulking. Again, 4 centimeters tumor just shaved off around the tracheal region. However, unfortunately, there was accidental tracheal injury there with some part of the trachea transected. And intraoperative assessment by the ENT showed there was a mucosal defect seen at the left piriform, extending to the left pharyngeal wall. So, and also from the wound, the ENT team can actually see residual tumor from inside. So at this point, Prof. Marina, intraoperatively, what can be done to for damage control of what we had done here?
Okay, so for the mucosal defect at the piriform fossa, if we still can oppose the mucosa, then we would repair the pharynx. using absorbable suture, and then we need to put a RAS tube, keep the patient near by mouth for about 2 weeks, do barium swallow, and off the RAS tube if there's no leakage. But
Prepare primarily,
prepare primarily if it can be opposed without tension. But if there is big defect, then probably we need to get whatever muscle around, rotate it to cover the defect.
How big is big?
We look at the when you oppose the mucosa, whether you can oppose it without tension. If you oppose with this tension, there's chance of there's necrosis, or they will break whenever you try to suture the two mucosa together. Then it would be better off you get a rotational flap muscle anywhere around to cover it.
Okay, so the ENT team helped us to repair primarily, and the patient recovered this session of surgery. So post-operatively, when she had recovered, she actually received.
Sorry, maybe may I interfere? There are a few relevant questions in the question and answer before we go to radiotherapy.
I actually cannot find my cursor.
Oh, you cannot find.
I cannot find my cursor that I.
Let me read out. Let me read out for you. There is a question about true cut biopsy. Okay, when is true cut biopsy indicated in patients suspicious of malignancy? Like the first question you asked that to Imi about doing the biopsy. So the question is, when is true cut biopsy indicated in patients suspicious of malignancy?
Maybe Dato Imi want to answer that?
Usually, to detect thyroid malignancy, FNAC is just adequate. However, there are only one molecular type of cancer, of thyroid cancer, usually cannot be diagnosed through FNA. If you suspect that this patient is having papillary thyroid cancer, means that FNA is just adequate. But knowing that if you can get a sample from true cut biopsy, you can just straight away diagnose all type of cancer, all type of thyroid cancer. But I just emphasize that FNAC is just more than adequate for the management of thyroid cancer. Because if you know whether it's papillary or follicular thyroid cancer, the management is almost similar. So you won't change the management.
Okay, for the second question for me to answer, from Marina, do you suggest tracheal or laryngeal resection during first op May 2020 to make sure all mass are resected? So go back to my answer just now. If total thyroidectomy, complete removal of tumor can be done, yes, ENT would proceed with clearance of tumor, like total laryngectomy or resection, anastomosis during the first surgery. But if the endocrine team just debulk the tumor, they wouldn't do major airway surgery. Another question is by to Dr. Liu. In cases of bilateral vocal cord palsy with just slit gap, how high is the risk of injury when intubating through the bilateral vocal cord palsy?
Bilateral cord palsy, when you are intubating, I would always paralyze and make sure that the cords are relaxed before you slide your ETT in. Instead of you risk, without relaxant, you risk the patient fighting and you cause a lot of injury like my photo earlier on. How high is the risk? That will depend on how good is your induction and your relaxation technique without a muscle paralysis. So again, it's still how confident are you with your technique when you're inducing.
So meaning it is still possible if you're confident to give muscle relaxant.
Yes, I would suggest it's muscle relaxant. Get the cord relaxed before you intubate. Without muscle relaxant is the one that I think is the question asked. That you risk all the injuries.
Thank you, Dr. Liu. From Nani, there are no more other questions in Q&A box now.
Yeah, I can open it now, but I don't know how to close it now. So the if the patient eventually received radiotherapy, maybe I can ask the last question to Prof. Wan Zamania. What's the advantage of RT here as compared to again radioactive iodine in this patient or even TKI?
I'll answer about the TKI first.
Yeah.
Usually we use that in the metastatic setting, not as in local recurrence when it's still amenable for local therapy. So the advantage of radiotherapy. Did this patient receive radiotherapy in my center?
I think HKL.
I think.
Mm.
Anyway, the advantage. If this patient is my patient, I will give radioactive iodine first, then only radiotherapy.
Mm-hmm.
But I'm not sure what happened. So maybe he or she did receive radioactive iodine followed by radiotherapy. But the advantage of radiotherapy in this situation, being the tumor is not 100% gone, like only debulking surgery, the gross tumor is still present. So that is actually a call for radiation therapy here. So radiotherapy, the role is actually to treat the remaining gross tumor.
Mm.
But radioactive, I still think that this patient need radioactive iodine if he or she have not got
I
any
think
yet.
this patient actually received radiotherapy and not a radioactive iodine. Maybe probably because based on the discussion that she had with the oncologist over there in HKL, that it's because probably she defaulted a lot of radioactive iodine treatment.
I think.
So I'm not quite sure whether that might be the reason for it. But it has got some advantage over here, yeah, the external beam.
For local control in a way as adjunct therapy to your surgery.
Yes.
Because of the gross tumor or R2 resection.
Okay. The patient was okay. Was last seen in August by ENT. There was no local recurrence anymore clinically, and she was, I think, due for follow-up again in the oncology in HKL. I think because of time constraint, I've got to stop here for the case discussion, and I might not be able to proceed with the next case. So maybe Prof. Go, we take a break, yeah?
Yeah, thank you so much, Dr. Han.
Now 4:38. So
Yeah.
10 minutes or 5 minutes?
10 minutes, 10 minutes.
10 minutes break, yeah?
Yeah.
And we'll reconvene in 10 minutes time.
Yeah, so 10 minutes from now, we will join back for the session 2. But in the meantime, there will be a video from Medtronic about the intraoperative nerve monitoring. So all of you, those who are still, you can enjoy the video. So see you back in 10 minutes time.
Thank you, everyone.
Bye-bye.
Thank you.
Thank you.
I dah stop share tak?
Dah.
Okay.
Hai Nani.
Itulah, I'm very bad at these technical things.
People can still hear you.
Melvin, are they able to hear us still?
Yes.
Oh, okay. We'll see back in 10 minutes time. So we shall view the video.